You are listening to the global network of podcasters dedicated to the pharmacy profession. Welcome to the Pharmacy Podcast Network.
Adverse drug reactions, or ADRs, are a serious issue in healthcare today. The pharmacist is the last line of defense to help prevent ADRs. A rising role of the pharmacist is the specialist who focuses on our children. Pediatric pharmacy ensures safe and effective drug use and optimal medication therapy outcomes in children up to 18 years of age. Currently, there are more than 1,450 board-certified pediatric pharmacy specialists, known as BPS. If you're interested in this expanding field of pharmacy, this podcast is for you. All right, everyone, let's give it up for our host.
Hello, listeners. Welcome back to the Pediatric Pharmacist Review. I am your co-host, Justin Cole, along with Mary Vuong. Mary, how you doing today?
I'm doing well. I'm so happy that we're talking about this topic today because it's super exciting and it's honestly one of my favorite topics. But thanks for having me again, Justin.
Oh, yeah. I'm always excited to have these conversations with you. So our topic today is the ketogenic diet, and this is something that is near and dear to my heart as well, being in pediatric neurology for a number of years. And we've got a couple guests that are absolute experts in this area and are passionate about it as well. So today we have John Cokley joining us again today. John, thanks for joining us on the podcast.
Yeah, happy to be here. Thanks for the invitation.
You're welcome. Hey, and we also have Lauren Kronisch with us. Lauren, thank you for joining us today.
Thanks for having me. Happy to be here.
Absolutely. Well, Lauren, let's go ahead and turn to you first. I would love for you to briefly introduce yourself to our podcast listeners, and I'd love to hear about your role in supporting children who are on a ketogenic diet.
Sure. So my current role is as a clinical coordinator at Texas Children's Hospital in Houston in their ketogenic diet program. And I've been a registered dietitian for 10 and a half years. In the last 8.5, I've been working over a year with kids, infants, and young adults who go on the ketogenic diet for various underlying reasons, typically that cause intractable seizures and other genetic movement disorders.
Great. Well, we're excited to have your expertise here. We've got multiple different angles at the table that are all so necessary for supporting these kids. John, I'd love to hear a little bit more about your experience in supporting children who are on a ketogenic diet.
Sure. So I'm also at Texas Children's Hospital. I'm a clinical pharmacy practitioner. I've been here for about 6 years, and I've been working in the pediatric epilepsy and pediatric neurology space for about the past 13 years or so. My primary role with helping to manage patients on the ketogenic diet is oftentimes helping to minimize carbohydrate content coming from medications, as well as helping to come up with medication regimens to help ensure that we're able to treat our patients without impacting the amount of sugar that they're receiving.
What inspired you both to specialize in pediatric ketogenic diets? It's very niche, and I feel like if you work in the realm of neurology, like it's our bread and butter. We totally know it, we love it. It becomes such a normal part of our practice. But what inspired you both to specialize in this?
It was handed to me in my first job as a registered dietitian, where I was an inpatient pediatrics dietitian at a mid-sized community hospital that happened to also have a neurological institute and focused a lot on inpatient neuro and TBIs and rehab. And so I became trained there through Johns Hopkins curriculum to do the ketogenic diet in a much smaller program than the one that I work in now. And I became passionate about it because you could see the positive difference that you're having on your patients, whereas a lot of things in nutrition, you're doing the right thing based on evidence-based practice, but you can't necessarily see it manifest as clearly as you can with the ketogenic diet. So it's just inspiring that you can see the positive impact that you're having.
John, what about you? How did you get involved in this idea?
Sure. So certainly I've managed patients on ketogenic diet at some of my prior institutions, but it's actually one of the major principles in terms of why they wanted to recruit a pharmacist at my current institution. They specifically wanted someone to help manage some of those kind of medication-related issues. I think for me, kind of an interesting backstory, one of the fun things that I did with kind of initiating with ketogenic diet was actually trying it myself. So I think for me, going through the process of actually trying it myself really helped to open my eyes to really what our patients are experiencing.
I actually remember that because I think I met you in Miami when you were starting it and you were just like talking about how hard it was. So for our listeners out there who don't really know what the ketogenic diet is, what is it and how does it work for children?
So the ketogenic diet is a broader term that encompasses several different diets that many programs do, but they're all high-fat, low-carbohydrate, and in pediatrics, moderate protein diets. And it's through the combination of the low carb and the high fat that it enacts a neuroprotective mechanism to improve seizures. And in many cases, we're not sure if it's its own thing or there's something about it that counteracts side effects from many anti-seizure meds. So we see anecdotally and described a little bit less in research, but kids becoming more cognitively aware, able to obtain more developmental milestones, and have improved moods.
So maybe we could get a little bit practical too. So what are some of the steps to initiating the ketogenic diet in a child, and how do you as a dietitian guide them through that process? Of course, there's a lot of prep up front, things they need to know before you just dive into a massive change in the diet like this. So what are those steps that have to be taken?
When the ketogenic diet is done through a program and covered by insurance, I'll focus on that, though there are many great private practitioners out there, and I actually moonlight as one of them myself. But I'll say through our program, a patient must be referred by their epilepsy doctor, which tells us that they think they're an appropriate candidate to try the ketogenic diet. And then they undergo a series of labs and an EKG. And in some cases need to get cleared by preventive cardiology or renal if that's needed to ensure the diet's a safe option before we even see them for an initial consultation appointment. Once that's all cleared, then they have an initial appointment with the doctor and the dietitian where we take a thorough history of their diet. If we think any of the ketogenic diets that we do would be feasible for the family, and also a detailed seizure history about many medications that they've tried and where they're at with all that. After that, then we decide which form of the ketogenic diet is the most appropriate option altogether in that first visit. And in our program, it's an elective 3 to 7 day inpatient admission for the modified or classical ketogenic diets. And modified Atkins or low glycemic index treatment diets are an outpatient education session with our nurse coordinator and dietitian that are approximately 1 to 2 hours. Then we usually follow up a month after diet initiation and for every 3 months for the first year in a combo of dietitian only and dietitian and physician visits to make sure everything's going smoothly and that children especially are continuing to grow normally.
So Lauren, you perfectly segued into the next topic. You talked about a modified Atkins and all these kinds of different ketogenic diets. What exactly is the difference between each one? And then how do you decide which one is best for the child?
So the classical ketogenic diet is a 4-to-1 ketogenic diet and is rarely the first diet tried. And to just break down what those numbers mean, 4-to-1 means for every 4 grams of fat in the diet, there's 1 gram of net carb plus protein. And so it's a very high fat, low carb diet, very difficult to do, especially if somebody was eating a normal diet before that. Not as difficult if somebody's primarily formula fed. But usually what we're looking for is what is the lowest ratio that we can obtain for the highest improvement in symptoms. So we don't want to start at the highest level because there's more of a chance of adverse symptoms, whereas we can go up over time to that level if we need to. So a modified ketogenic diet would be anything from a 1-to-1 up to a 4-to-1 ketogenic diet. And then those are the types of diets that are primarily started in our program, inpatient, and some other programs, they do outpatient starts for those kinds of diets as well. And that same calculation of nutrients would qualify for the ratios below it. So like a 1-to-1 ketogenic diet is for every 1 gram of fat, there's 1 gram of net carbs plus protein. Modified Atkins diet, we do somewhere between 5 to 20 grams of net carbohydrates. And then they're unrestricted in fat and protein, but encouraged to add fat to every single time that they eat. Low glycemic index diet is a little different depending on which program that you're in. For ours, we prescribe a macronutrient pattern, and so it is pretty detailed as well. And so how we choose is usually what is the amount of time families have to be able to dedicate to food preparation, how many other children are in the house, how many resources do they have for helping with food preparation. That definitely influences things, as well as how picky is the child. We have some, toddlers who are very picky eaters and eat very high carbohydrate diets. They would be much better candidates for a modified Atkins diet. And sometimes even those patients are given diet homework to try some of the products that they would be having in place of their normal high carb items.
Well, I think it's so important to understand that no two ketogenic diets are created alike. And you've done a great job of kind of highlighting how this is the case. And you've also highlighted some of those challenges that families might face when they're transitioning. John, I want to turn super practical and ask you, you've tried the ketogenic diet or some form of it, right? So what was your experience like? What were some of the challenges you faced as an adult who was able to make these decisions and do that on your own?
Yeah, so certainly one of the things that I kind of make jokes around with the diet is it's not necessarily just a diet where you can just go and eat all the bacon you want. I certainly do love to eat bacon. One of the ways I have kind of introduced even the concept of a ketogenic diet for adults is to eat a lot of avocados. So I tried stuffed avocados as the way of kind of introducing that diet. And the reason why I do it is because it's kind of naturally a 4-to-1 ratio. But avocados are very tough on the stomach if you're trying to eat a large amount of them. So for me, the kind of GI side effects, of kind of feeling that nausea was really one of the biggest things that I noted when first starting on the diet. It takes a little bit of time to get used to. And kind of similarly, where they talk a lot around the kind of energy expenditure from being on the ketogenic diet and how that's different compared to my kind of natural kind of citric acid cycle and how that works in terms of energy production. What I did notice is after I got used to being on the diet, I did feel a lot more of those cognitive benefits.
And John, you touched a little bit about the nausea and how hard it is to tolerate it. From a pharmacist perspective, what role can you play in side effect management? Because it's not fully benign, which is why it scares me sometimes when people do it for fun and to lose weight, because I'm just wondering, are you monitoring X, Y, and Z? So what can a pharmacist do to help with all the monitoring?
Sure. So there's a variety of kind of monitoring styles that are out there. The thing too, we're going to be looking at your beta hydroxybutyrate, which is kind of considered to be that serum standard. That's actually based off of our ketone body expression. So BHB is expressed about 3-fold higher compared to your other ketone bodies. I do kind of point out that between ketogenic diet, the classic diet, compared to your low glycemic index and your modified Atkins diets, classic keto diet is going to have a higher ratio, so that BHB can be somewhere in the range of about 2.5 to 5, whereas your low glycemic index and your modified Atkins diets can be a little bit lower. It's a great number that we can measure within the hospital. On the outpatient basis, a lot of times what you can do is see ketone strips that are used to kind of assess for the amount of ketones that are in the urine. One thing that I kind of point out for our patients when we're doing that kind of transitionary phase when they're in the hospital is we kind of tell them to monitor to see what is the kind of ketones that they're producing at their kind of target BHB, so that way they know if those numbers go higher or lower. That would be kind of a surrogate marker to kind of highlight for us to be aware of.
So going back to this idea of planning before a child is started on the ketogenic diet, we know that there are carbohydrates in all kinds of things beyond foods, including the medications. So I'm going to ask Lauren this question first. What is your view of the importance of having a pharmacist involved with caring for kids who are going to be started on a ketogenic diet? How do you interact interprofessionally with the pharmacist?
I think invaluable. Before John was involved in our program, we were left to trying to look through LexiComp ourselves, which we only use so often, or the database on Keto Diet Calculator, which is incomplete and doesn't have all manufacturers for all medications listed either. Where they're great resources, but they're just not entirely comprehensive or easily accessible to someone who doesn't use them all the time. And so adding John onto our team, especially for emergent starts that are started in the ICU, just really helps streamline the care and increase the time of access to the care with starting the diet. So anytime somebody is evaluated after that initial consultation in outpatient clinic and then cleared to start the ketogenic diet, they go to John or one of John's fellows to create a comprehensive note for the inpatient team to have ready when somebody gets admitted to start the diet inpatient, or to access for prescription changes to be done ahead of time so that when they come for their outpatient education teaching, there's no confusion about which medications need to be changed over.
Just going off of that, one of the biggest roles I remembered in the hospital with converting a patient over was converting from like oral solutions to tablets. And a lot of times you've had to get pretty creative. So I guess this question can be for the both of you. What's the most creative thing you've had to do, whether it is with diet or with medicine for the keto diet?
Sure. So I'd say from kind of a medication perspective, now obviously the biggest goal that I have is minimizing the carbohydrate content of medications. And when we're talking about patients who sometimes, when we think of our kind of traditional conversion for tablets, we're looking at doing things like 1/4, half, 3/4, or a whole tablet. But that's not always feasible for some of our patients. And then, even within that, sometimes we have to kind of crush those tablets and mix it into water in order for them to be able to take it. So I would think probably one of the most unique things that we've done is actually custom compounding solutions for patients. And the reason why I bring that up is when we think of how we would normally, crush, we essentially are using suspending agents. Some of the suspending agents that we commonly use for compounding of outpatient medications typically do have a lot of sugar in them. Even if you're looking at some of those sugar-free formulations, those sugar-free formulations also have sugar in them. They're just not listed as, carbohydrates, on the package insert. So they might have other carbohydrate containing sources, even though they say, contains no sugar. And so we've actually worked with compounding pharmacies in the area to make oral suspensions for patients so that they can still remain ketogenic compliant, even if they do require oral suspensions.
What you learned? Have you had to do anything super creative for your super picky eaters? I remember seeing the epilepsy kids at summer camp who would have to have like all their food packed. And I remember there was one kid that it was like every day had, I think, 4 avocados, alfalfa sprouts, and like MCT oil drenched all over it. And he was a trooper. He just like ate it because he had to. But what are some creative recipes and things you've had to do to have kids tolerate the keto diet more?
That's a good question. To be honest, I think food companies have helped with this part because there have been such a prolific amount of specialty foods that have come onto the market and are available in main grocery stores than there were even 5 years ago. Now, whether they're truly strictly keto the way we need them to be varies and is a point of education, certainly in all of our sessions. But I think it's often taking a cultural or family recipe and seeing if I can modify it to be keto compliant. One of the biggest ones are Thanksgiving recipes, which they're not tough, but I'll say I tried back when mashed garlic cauliflower was still a newer thing. I brought it to my own family's Thanksgiving and didn't tell them what it was until later, and nobody knew. So I think it's just really calling to the food science education that I was able to have when I was at Rutgers and still use some of those same textbooks when I'm looking, like, if I modify something for something else, is it going to, change whether a product can rise in the oven, for example, is really important. And also where I hope we can get a chef involved at some point in the future as well.
That would be a great idea. Get some creativity on top of some scientific knowledge, and you can come up with some cool stuff. So I'm also a little bit curious about how, John, you and your team advise patients and parents about OTC medications. Clearly, we know that febrile illnesses are common, especially in young kids. What are some of the things that you advise the families on related to that?
Sure. So OTC products tend to be things that we try as much as possible to kind of plan for in advance. So if you're thinking your general kind of cough and cold type things, we do provide them with counseling and set up plans for them in terms of ibuprofen and acetaminophen, so that they have those doses in advance. Probably one of the other things that comes up as far as OTC products is really a lot of our GI meds. So things like if they're requiring buffering, for example, some of the products that we're using essentially are going to be products that they might get off of Amazon, for example, so that we actually do provide them with how to calculate that and how to create their doses for those. Kind of similarly, your OTC, usage of things like, your proton pump inhibitors and your H2RAs. We also provide them with dosing for that as well. There's actually a table that at one point I put together for our GI service, because we do have a large number of patients that are seen both by our ketogenic diet team as well as our GI service. So they actually have a giant table that's already kind of pre-prepped for them that gives them the common, dosage forms that they can use, as well as the subsequent carbohydrate content that's available in each of those medications.
It's interesting you bring that up, because I feel like PPIs are the worst when you're trying to convert a patient to keto, because one tablet of I think lansoprazole is 1.6 grams, and a Nexium packet is 3 grams of carbs. So really there's not a good option besides doing the omeprazole with sodium bicarb.
Yeah, that one definitely comes up very frequently.
So what do you normally do?
We tend to use probably lansoprazole ODT most commonly. It's got about 169 milligrams of carbohydrates in it. It's the one that's part of our formulary, so that's kind of why we tend to use it the most. But one of the things that kind of does come up with that, especially if we are trying to get it covered by insurance, is insurance doesn't always cover for us to interchange between PPI products. So some of the times it's just a matter of seeing what their insurance covers, and then seeing if that's something that's ketogenic diet appropriate. And there are times where we actually have kind of a standard template letter of medical necessity for cases where, for example, if their insurance says, oh, we want you to use this product, and that product itself is not compliant with the ketogenic diet.
I remember we would run into issues with that all the time. And then I think the issue with the ODTs is that sometimes it's a culprit for clogging feeding tubes. So how do you both deal with feeding tubes and the ketogenic diet?
I call John. No, just that's true, actually. Unless they're sometimes, we have a blenderized. Sometimes we have people on blenderized feedings, and it could clog for that reason too. But no, yeah, I defer to John.
Fair enough. Yeah. So certainly I would say it's great for our kids that are receiving buffered therapies. So by buffer, what I'm referring to is the use of either potassium bicarbonate or sodium bicarbonate. So almost think of this as the equivalent of, club soda, for example. So for patients that are on that, then sometimes we're able to use that to try and help clear the clogs if clogs do occur. So I certainly say even some of the medications that they're receiving for seizures, sometimes they have kind of sprinkles inside those capsules. And that can very much be an issue for feeding tubes. Ideally, if I have a choice, then obviously I would choose large bore feeding tubes for patients. Anything that's larger than a 14 French would be ideal, because it does help to decrease the amount of clogging that you end up getting with that. The reason why I kind of bring it up is because if you look at most of the kind of manufacturer recommendations on how to minimize that, what they'll say is, oh, we'll administer it with applesauce, and that's obviously something that's not really going to be feasible for ketogenic diet patients. So being able to kind of have a large bore feeding tube and to be able to use essentially those buffering products, you're almost able to kind of force flush it through. It's one of the ingredients that's in Clog Zapper, actually.
Have you all ever used, I used to have to use this a lot because it binds to like the fats, like Creon with sodium bicarb. You make a little mixture. There's like a good recipe for it. And if you think about it, it's really smart because like the Creon helps with the fat and then the sodium bicarb helps break everything up. So I always try to recommend that. And then I guess how are both of your feelings with like club sodas and things like that? Because like when I walk into a room and there's like seltzer or something sitting there and they were using it with the feeding tube, my heart like drops a little bit.
Sure. It's been a very long time since I've actually seen that Creon mixture. But yeah, that's actually a great one that we can use. I would say I tend to use it more on the inpatient side than the outpatient side, just because obviously the insurance companies will look at you kind of funny if you're saying, hey, I just need, 6 or 10 Creon just for in case a G-tube clogs. It does get, it gets looked at a little bit sideways because it's traditionally used as a medication that we give to our CF patient population. But that combination does work really well, and I've definitely done that on the inpatient side for patients that get clogs. As far as kind of utilizing, club soda on the outpatient side, it is something that we tend to be a little bit more cautious of, just because not all club sodas are the same. I kind of make the joke. We actually have essentially like a carbonated water that I used to get from the hospital. And for the longest time, I used to say, oh, this tastes so great. Like it's just a flavored, strawberry flavored water. And it was a long time before I realized that that particular brand had a significant amount of carbohydrates in it. And so that is something that we need to watch out for. Not all club sodas are created the same. Some of them do have flavoring in them. Some of them do actually have carbohydrates in them. And even with that, some of the other preservatives that are in there can also be problematic as well.
Well, speaking of buffering and a couple other things, it's a great segue to talking about some of the risks of the ketogenic diet. I think the mainstream media with the type of ketogenic diet that has been proposed for weight loss doesn't necessarily have a great understanding that this isn't a benign diet, especially when we're doing 4-to-1 ratios for a kid to treat their epilepsy or something like that. So, Lauren, maybe you could start with telling us what are some of the concerns that we have with the diet that we need to monitor for?
The most common side effect when somebody first starts, but one that is effectively treatable, is constipation. I would say if somebody has a history of constipation, it will often get worse their first couple weeks on the ketogenic diet. And even if they didn't before, I see it in maybe 70 to 80% of people when they first start the ketogenic diet, but very effectively treated with adequate fluid intake, increased fiber, and then usage of different constipation medications. And so that one I consider more of like an acute beginning problem, but I know you're referring to some other, overall adverse risks. Generally, kidney stones is a possible risk on the ketogenic diet. I've only seen it, I would say 15 times maybe in my 10 years of practice. So this is where I think being followed regularly by an experienced team is important, because if you have a dietitian encouraging adequate fluid intake and you're taking, randomized urine calcium creatinine levels that would maybe detect an increased risk before you might actually have stone formation, you can then, use more or start a prophylactic buffer to help against the acidity that we know the diet can cause in people's systems, and make sure that they are consuming enough fluids. And sometimes they're really not, and it takes a lot of work from our side to make happen. And so sometimes the risk will go away just from those kind of preventative interventions. But sometimes, we have some children and people who are complicated, and it's something that will still occur. And then it's an evaluation of how much has the diet improved this person's life, and is it worth managing through the kidney stones to stay on the ketogenic diet? Or perhaps if they have something more like a 20 to 50% response rate, how bad are their stones, and do we want to consider coming off temporarily the ketogenic diet? So I think it's really important to know not all ketogenic diet teams are gung-ho that keto is the only great diet out there. I think it can be very effective, and certainly all Americans could have less processed carbs and added sugar, but it doesn't mean that everyone needs to be on the ketogenic diet. And it doesn't mean that everyone needs to be on the ketogenic diet for life. But back to the other possible side effects. Hyperlipidemias is another possible side effect. It is well studied and researched that many people's lipids go up temporarily the first 6 months on the ketogenic diet and then normalize out. And so that's an important education point, because if someone doesn't know that and they're due for their physical, they might get nervous or frightened. And that's also why it's important to get good fasting baseline labs before you start the diet, so that if there's a baseline unknown congenital hyperlipidemia, that we get that addressed, or make sure that a cardiologist agrees it's worth the risks of trying the ketogenic diet for the other possible improvements. Other things, it's been well studied a little bit more in the last few years that there are some growth risk factors for being on the ketogenic diet that increase as the ratio level increases. And so that's another important reason why it's good to see if a lower ratio can have effective seizure improvement before you go to a higher ratio. Also, I would say pickier eating, growth for other reasons. So this is where, again, regular evaluation to make sure adequate macro and micronutrient intake is happening, and that there's not sometimes an increased amount of picky eating with the start of the specialized diet. That's important, and sometimes it's even a reason to go off if we can't, get a better handle on it, because we want to do more help than harm, of course.
Yeah, absolutely. So John, I'll turn to you. Talk a little bit more about buffering approaches. How much bicarb do you give prophylactically for patients? Do you give it prophylactically to every patient, or do you look at labs? What do you think the science tells us we should be doing for kids that are started on the diet?
Sure. So obviously most people are familiar. There is a actual calculation that you can use for acidosis. I will say you don't necessarily have to use that to kind of come up with your starting buffering dose. By buffering, obviously, we're kind of referring to either the use of something that's a bicarbonate product or a citrate product. So we're looking at essentially providing them some formulation of bicarbonate. You can do kind of an empiric dose somewhere in the range of 1 to 3 MEQs per kilo per day. In terms of who I might put on my radar for kind of just empirically starting that, obviously there are medications that patients can take for epilepsy that will increase your risk of acidosis. So think things like topiramate, for example, significantly increases your risk of metabolic acidosis. Similarly, zonisamide can as well. For patients that are on that, we're probably going to start them empirically on 1 to 2 MEQs per kilo per day. And then we'll monitor them with the initiation of the diet to see whether or not we may need to make further adjustments. One of the other things that we'll kind of look at, Lauren already kind of mentioned, was that urinary calcium creatinine ratio. If that ratio is greater than 0.2, then we're also likely going to start you on some type of buffering agent, because the studies have shown that the risk of developing nephrocalcinosis is higher when a number is greater than 0.2. Now, one of the things that's kind of been brought up, particularly because one of the main manufacturers discontinued, is what product do you use for buffering, right? So oftentimes we hear, oh, well, do you put them on sodium bicarb? Do you put them on potassium bicarb? And then, long ago, if you're old enough to remember it, there was a potassium citrate product called Citrate packets that were also used. Now, there is evidence available to show that if you have a patient who is at elevated risk for nephrocalcinosis, your potassium bicarbonate or potassium citrate, which was originally the Citrate packets, is considered to be the preferred formulation to treat them with, because while both products essentially can provide you with buffering, if you're using sodium bicarbonate, the patients can still get sodium oxalate crystals, and so they essentially get crystalluria as an alternative. So you're really not getting around the problem. So now that we no longer have that Citrate product, there is still a effervescent tablet that's available. So we kind of call it Effer-K, which is essentially just an effervescent potassium bicarbonate. They have multiple formulations that are available. Comes in 10, 20, and 25 MEQ tablets. Now, one thing to kind of point out that comes up pretty frequently in terms of which product to use, some of them come flavored, some of them come unflavored, depending on the formulation that you're using. The flavored formulations actually have less carbohydrates in them. So that's one thing that becomes a very frequent question from families. Oh, I have this cherry vanilla flavored tablet that I got. I can't take that because I'm ketogenic. Well, it's actually the flavored product that actually has lower carbohydrate content. Is it a huge huge amount. If you're using that 10 MEQ product or the 25 MEQ product, it's usually not a big deal. However, some institutions do use the 20 MEQ effervescent tablet. And so if you're using the unflavored formulation for that, that can be about 160 milligrams of carbohydrates. One single tablet, not a huge deal. However, what ends up being the kind of conversation piece is how much of effervescent potassium are you using? Because, typically if you're requiring a large amount of FRK, then that's going to kind of make those carbohydrate numbers go up a little bit further. Kind of similarly, for patients that are receiving just plain sodium bicarbonate buffering, the tablets also do contain about 95 milligrams of carbohydrates per 650 milligram tablet, so about 7.7 MEQs. So for our larger patients, they can oftentimes require a large number of tablets for sodium bicarbonate as well. And so that can also become problematic because then the carbohydrate content becomes so high that it's actually not feasible for the diet anymore. And so for some of those patients, we actually have to transition them over to using baking soda powder. So essentially, you're kind of cooking baking soda. 1 teaspoon is about 59 MEQs. And so that has to be used as an alternative.
And then, Lauren, you touched a little bit on hyperlipidemia and how that will level off as time goes on. What are both of your thoughts on levocarnitine and helping with the fatty acid transport?
So certainly a carnitine profile is included in those pre-keto screening labs that we take. And so that helps us see if somebody has a low free serum carnitine at baseline. And if they do, then we start prescribing for at least 3 weeks before they would even start a diet, because we know it would be more difficult to get to optimal ketosis without that good baseline level. And we do utilize it sometimes for increased ketones later on, but more often we would try other interventions first. We've also used it before to improve pancreatitis and other kind of fat metabolism issues elsewhere in the system. But I would say it's not the first intervention of choice for them. There are some kids who have GI intolerances to carnitine. And I have even seen anecdotally some kids who will have an increase in seizures as a result of it. It's not very common, but it's enough that if there's something else that we know that might be effective, then we might try that first.
Yeah, I definitely would agree. Probably one of the outliers that I would say to that where we might use carnitine is probably going to be more on the keto TPN patients. So that's typically going to be our ICU patient population. One thing that I'll kind of point out with keto TPN compared to taking like an enteroketogenic diet is they're actually at much higher risk for seeing alterations in their lipid profile. And so using the IV carnitine within their TPN is probably the one time that I would use it.
Oh, that's super helpful. One of the common questions I would get when I was on a ketogenic diet team was how to approach hypoglycemic episodes. And of course, this is something that is drastically different than in most of us if we were to have hypoglycemia or thresholds and so many other things. So could you talk a little bit about your approaches? How do you encourage families to recognize and then treat or not treat hypoglycemic events?
Sure. So I'll say this is something that we even talk about on the inpatient side. I think because, especially from like a nursing perspective, we're always kind of taught that, these are the threshold markers for hypoglycemia. It's going to pop up red on your, whatever results tab that you're using. But I oftentimes have to remind services, especially if they're not familiar with managing ketogenic diet patients, being, in your quote, hypoglycemia area is very normal for patients that are on ketogenic diet. And by normal, I mean, for a patient that's on ketogenic diet, it's not uncommon for them to have a blood glucose somewhere in the 40 to 70 range. The way that I kind of explain that to people is from the perspective of how would you have sugar in your blood if you're not actually eating sugar? Right, because you still need to have that present. So that's usually one of the first things that we kind of do. Outside of that, usually what I do is provide education, obviously on the symptoms of hypoglycemia. But for our residents, usually what I'm teaching them is the management approach. And so the management to hypoglycemia for a ketogenic diet patient is significantly different from how we would manage hypoglycemia in another patient. So generally speaking, if we have patients that are kind of, still conscious and, on the acute care floor or being managed at home, we're using somewhere around 15 to 30 mLs of orange juice, right? So if their blood glucose falls in the range, let's say, for example, of about 25 to 40, then we'll give them orange juice of about 15 mLs. And so it's roughly about 1.5 grams of carbohydrates. And then we'll recheck their blood glucose after that to see if they get back within that ketogenic range. If they are less than 25, then we can give 30 mLs of orange juice, and then we'll do a recheck in about 15 to 30 minutes. And again, we're trying to see if we can get them back in that 40 to 70 range. The reason why we typically don't want to give more than that is because if we're giving them a large amount of glucose, even if we're giving it, for example, for the treatment of hypoglycemia, if we're using a large dextrose or a large glucose treatment dose, you run the risk of precipitating seizures, right? Because you actually want those patients to have a lower blood glucose because they're in ketosis. If you're giving them a large amount of carbohydrates at a single period in time, then you run the risk of breaking ketosis altogether. And so if that occurs, then you're essentially running the risk of having breakthrough seizures.
And I guess we also touched a little bit on keto TPN. I know that it's something new, innovative, and I think we only did it once when I was in the hospital, but can you touch a little bit on that and how it differs? I know one of the biggest questions people have is like, oh, is it too like hypotonic? Will it hurt you because it doesn't have the dextrose in it?
Yeah, so that certainly does come up because you're not giving as much dextrose. It's almost, I would say, the same as initiating a traditional TPN. It's just without that, glucose component. So there are still similar kind of targets that we're having in terms of trying to reach certain electrolytes. They're still going to get, your lipids. They are going to obviously get a larger dose for their lipids. But the overall process otherwise, outside of the dextrose component, is roughly going to be the same. One of the biggest things that is probably going to be different between initiating a keto TPN versus initiating enteral ketogenic diet is how quickly they get into ketosis. And so patients are going to get into ketosis much faster with the keto TPN. And so that's where we end up having to kind of monitor them a little bit more closely. It was typically for us is going to be patients that are going to be initiated in the ICU setting, simply because those are the patients where we end up having to start the diet. If you're looking at kind of the traditional process of initiation of the ketogenic diet enterally, you kind of have that traditional, starting at a 1-to-1 and then escalating each day, whether you're doing, 1-to-1, 2-to-1, 3-to-1, then 4-to-1, and kind of escalating over time. Your keto TPN is going to be limited in how high you can actually even treat patients, right? So generally speaking, you're going to have a keto TPN that's going to be in the range of about 2 or 2.5 to 1. But even being at a lower ratio, patients are still able to get into ketosis using that keto TPN because you're essentially giving it, directly through their through parenteral therapy. So with those therapies, you're going to get into ketosis a little bit faster, usually in the range of about 2.5 days.
So I wanted to ask each of you about some of the patients who the ketogenic diet has helped most drastically. I'm thinking back to my practice of a patient who had epilepsy and had been nonverbal her whole entire life. But on day 4 of the ketogenic diet, she spoke her first words as a teenager. Like, I was in tears that day on the floor. It was just a really cool thing. So I'd love, of course, we'll respect privacy, but are there certain patients that just stick out to you where this has made a huge difference in their life, their quality of life?
Yeah, I mean, we've seen some people go from having multiple seizures per day to 0, and then also be able to successfully taper off some or all medications. That's not the majority of patients, but it's possible. And so, when you can taper off medications, then many of the drowsy and kind of side effects of many medications come off. And whether it's the diet's effect to increase cognitive awareness or just the lack of side effects, someone's ability to learn more in school, obtain more developmental gains, and just engage in life gets drastically different when that's possible. And I think some of the other cases that stick out in my mind are pediatric GLUT1 kids diagnosed late and then they start. And it's just like night and day in their personalities and how they interact with their families. And yeah, those are some of the most rewarding cases. People who are nonverbal become verbal, people whose mood improves significantly. I know it's being studied a lot more now in, the context of ketogenic diet therapy for seizures and also for mental health as a separate comorbidity. But it's really interesting, and I'm very curious to see what more research yields from that as a result, because we know the possible comorbidity of mental health issues for people with epilepsy is much higher than the average population. So, seeing kids whose affect goes from flat to much more engaged and they seem to be happier is also very rewarding.
Yeah, and I'll definitely take it a step further. One of the things that I don't think that we appreciate enough is the peace of mind that it can give for families, in terms of having a dedicated team that's helping you through such a difficult initiation process. I think kind of two patients that really stick out to me. I still remember one of my first cases when I started dealing with keto here. That particular family has still sent me like Ketoversary photos and kind of just said, thank you so much for all that the team is doing. I think for some of our more complex cases, I have, a family that, can reach out to us directly, whenever they have, admission, concerns. Particularly, one of the things that I think comes up for us is being that we are a tertiary referral center, we do get patients that are not just in the Houston area. And so there can be a lot of anxiety with managing epilepsy in general, and then adding on to, the complexity of being on a ketogenic diet. And for example, having to go to a outside facility that may or may not be familiar with managing ketogenic diet. There's a lot more pressure and anxiety that goes on to the families in terms of, am I going to be seen by someone who knows how to manage that? And so sometimes they do reach out to us and kind of ask for, advice on therapies to help manage patients, even though they're not necessarily admitted to us.
Well, I just think it's amazing to see some of the stories that can happen. And again, it doesn't work for everyone. Not everyone can tolerate it. It may not be the perfect thing for every family, but when it works, man, it's a lot of fun to see. I'd love to know, are there any practical tips for the pharmacists that are listening that may not be involved with patients that are on a ketogenic diet every day? Maybe they're involved with transitions of care or other aspects of a child's care. Maybe each of you, are there 2 or 3 pieces of advice that you would give to those pharmacists about how to properly care for kids that are on these diets? And Lauren, maybe I'll start with you.
Yes. So first of all, if you're a pharmacist in an institution that does not have a ketogenic diet program, but it's a patient in your care, and it could be somebody who self-started keto on their own, or they're seen elsewhere, I would just encourage them, if they are a self-starter, to be followed by a team if they have one accessible to them by geographical location, or perhaps even with an experienced private practice dietitian at least once a year, just to kind of keep an eye on risk for adverse effects like we discussed. By checking out the Charlie Foundation's resources page, there's a list nationally and internationally of programs and recommended private practitioners. That's a great resource to just be able to give families. It also contains testimonials there of what it's like to be on the diet from the parent and the child perspective, and contains recipes and a lot of other great stuff. So I think that would be the biggest one. Just encourage them to follow with somebody who's experienced in the ketogenic diet, dietitian, physician, if possible. But at the very least, certainly there's a decent set of annual screening labs that should be interpreted by someone who knows about the ketogenic diet to advise on if anything needs to be tweaked about their ketogenic diet to help make the diet be safer and to mitigate risk factors if there are any showing up in their annual screening labs. The next is, and I know this isn't the pharmacist's job, but just if someone encourage the team, take a quick look at a child's growth chart. And if they see anything concerning, recommend outpatient follow-up, either with the pediatrician or with the dietitian if they are following with the ketogenic diet team, because certainly one thing that we're always trying to make sure is that we're doing more help than harm. And we want to make sure that if someone hasn't come for follow-up for the ketogenic diet, that they're growing and getting the nutrition that they need to be able to do that.
That's great. John, what other advice would you have?
Yeah, so I'll kind of second that, utilizing your resources is incredibly important for this patient population. Within the Charlie Foundation, there is a wealth of knowledge that's available that is readily, accessible. So for example, things that we don't often think about, no carb and low carb personal care products, right? I've certainly seen there have been times where we've had issues with getting patients into ketosis simply because of the toothpaste that they're using. And so some of those things, especially as a pharmacist, are not going to be on the forefront of your brain because you're thinking about medications. But these are very much things that are going to be part of, a patient's regular, daily life. As a pharmacist, we are going to focus oftentimes on the medication components and really knowing what resources to access in order to minimize the carbohydrate content of medications is going to be, paramount. There are generic resources available, so you can look at Lexicomp, for example. For those that are interested in kind of establishing programs, I would certainly recommend to be a part of, the Charlie Foundation. There's a ketogenic diet calculator that's available, and it can give you much more manufacturer-specific information. And there's obviously publications that are out there. We've certainly done our own publications on high-risk medications. So when I think of high-risk medications, I'm thinking things that we don't typically think about. So for example, IV medications are oftentimes overlooked. We just think, oh, well, I'm going to put them on IV Tylenol. Well, IV Tylenol has mannitol in it. That's something that, depending on what your institution requirements are, you may or may not have policies against the use of that in your ketogenic diet population. A lot of our other medications that are used in the perioperative period also have IV carbohydrates in them, or they're actually made standard in dextrose at certain institutions. When we did this as a needs assessment at our institution, roughly about 40% of medications actually were made standard in dextrose. And not all of them actually have a routine alternative that's available. So it's important to understand your resources so that you know whether or not that's going to be problematic for you. Being able to understand the diet as a pharmacist is very important because it helps to minimize the risk of medication errors. Certainly, the pediatric epilepsy patient population in and of itself is one of the highest risks for errors, particularly the highest risk for errors that involve harm. So essentially errors that can cause a patient to go to the ICU. Having a patient who is on ketogenic diet, breaking ketosis from, carbohydrate administration certainly can get you a trip to the ICU. And so it puts those patients at a higher risk level. So one of the things that I kind of challenge organizations that are interested in starting these ketogenic diet programs is actually looking at how you as an organization can really establish a safe practice. And so it goes beyond, utilizing your resources, but creating a systematic approach. So things like establishment of a formal ketogenic diet service where there are people who are, well versed in the ketogenic diet and some of those risks. A systematic approach to how will you avoid inactive ingredients, particularly if you're looking at tablets versus suspension products. Having a formal ketogenic diet policy and procedure. At our institution for at least the past 10 years, we actually have a dedicated pharmacist protocol for even how to do medication profile review for patients. So even if you're not the ketogenic diet pharmacist for the service, you can at least look at medication orders as they come in and have a systematic approach to minimize the carbohydrate content of medications. Kind of similarly, when patients are being admitted, knowing how to reconcile a medication list and being able to look at that medication list to be able to determine whether or not patients are at risk for carbohydrates from those medications is important. Knowing how to, monitor your patients and knowing what the proper, monitoring parameters are for a ketogenic diet patient is very important. And it's something that, you're not routinely going to understand if you don't have a protocol and you're not used to managing those patients. We certainly have gone through our formulary as well and made formulary recommendation changes so that our medication products can be very much, more compatible with patients that are on a ketogenic diet. At our institution, I think we have a little bit over 200 patients that are on the ketogenic diet, so it is a little bit more of a priority for us. But certainly it's something that can still be taken into consideration for patients that are on the ketogenic diet. There are a lot of different forums currently that are talking about how to make, a safer admission for the ketogenic diet patient population, and a lot of that is focusing on how to make the EHR more functional and more capable of assessing for the carbohydrate content of medications. There's a lot of data looking at, what is the overall average amount of carbohydrates that are in a patient's medications, and so the average is somewhere around 600 to 900 milligrams of carbohydrates, and that's after you've actually converted those to the lowest carbohydrate formulation. And so it doesn't take much to push patients over that 1 gram threshold. That 1 gram threshold is used by most institutions as kind of a surrogate marker for when to have risk. It only takes about 1 gram of carbohydrates to actually adjust the ketogenic diet ratio. And so there's actually a pretty low margin for error when we're talking about the risk of breaking ketosis for these patients.
It's super interesting, and I agree that safety is one of the biggest things, because I remembered coming through after a weekend, one of the biggest med errors was oh my gosh, the ketogenic diet patient was given dextrose by accident, or there was dextrose in the diluent, or it's honestly so risky, because one little thing can break ketosis, and it takes a fine, I guess, lots of safeguards, but also just lots of paying attention. So it really just shows the importance of the team-based approach with the ketogenic diet. And that's probably why it's one of my favorites. It takes a village to really maintain and take care of a child, but the outcomes are so great. And with that, I think that you guys both did an amazing job, and we loved having you, and we could honestly talk about the ketogenic diet forever. We picked the perfect group of people to do this, but thank you both so much for joining us today.
Thanks for having us and for asking good questions.
It's a pleasure to be here.
That's all for today's episode. Thanks for listening, and remember to subscribe on Apple Podcasts and leave us a review.